The primary indication for lift control is external sinus floor elevation. We'll now show you a practical demonstration in the left maxilla. To begin with, the operation site is exposed.
Das ist eine Vorkörnung.
The pilot burr is the first instrument used in order to prevent the subsequent twist drill from slipping off. A pilot hole is then made with the depth mark twist drill. The depth and diameter of this hole depend on the available vertical and horizontal bone dimensions, which are determined with the aid of an X-ray. The length of the hole should be up to 2/3 of the vertical bone height. The twist drill has a depth mark for this purpose. The conical reamer comes next. It should have a diameter of about 30% smaller than the implant to be inserted. This results in a perfect preparation for the surgical tap to be used next. The tap ensures the necessary horizontal bone condensation. It is slowly screwed into the prepared bone with the manual instrument. The bone condenses according to the tap's special shape. This is a particular feature of the compress implant system. Next comes vertical condensation with the bone elevator. In this case, the elevator with 2.6 mm diameter is used first. As a result, there is vertical condensation of the bone, but no elevation yet. The next instrument is the elevator with 3.0 mm diameter. This is used to further prepare the implant hole, and the condensed bone begins to be elevated into the sinus floor. This step is shown more clearly here. The sinus floor is now slightly elevated. The elevator with 3.6 mm diameter is used last. The drill hole is again raised up to 5 mm into the sinus floor. The now available implant hole is sufficient for screwing in the desired implant. The implant is screwed in as far as possible with the handheld instrument. Only if this becomes difficult is the ratchet used. The bone stiffness clearly increased by the lateral bone condensation and vertical elevation also results in optimal primary stability of the inserted implant. After this, the wound is closed.
Du machst mit Halbseiten-OPG anschließend, ja?
The lift control instruments can also be used for a simultaneous elevation of the implant and bone bed. For this, an implant can be inserted up to the maxillary sinus floor, provided there is a sufficient horizontal bone supply and a vertical residual bone height of more than 6 millimeters. After insertion, the implant initially extends beyond the alveolar ridge by the difference between the vertical bone supply and the length of the implant. A dissection is made up to the verge of the maxillary sinus floor with an appropriate Triffin burr. An elevation sleeve matched to the size of the Triffin burr is screwed onto the driver. The implant and its bone bed are driven in a cranial direction until the implant shoulder has reached the crestal level. The sinus floor is thus elevated. The resultant cylindrical crestal defect is filled in with bone chips and/or a bone substitute material. Additional friction of the implant may be required.